My name is Nancy Garrett. I am the Chief Analytics Officer for Hennepin County Medical Center, and I'm really excited to be here with this amazing panel. So I think we'll have a lively and interesting discussion. And MDH just informed me that at the end of the session, everyone will be handed a free iPad on the way out. Just kidding. But I have seen that as a tactic to keep people through the very last. I was asking if there's going to be a drawing or something, but I'm impressed that you're all here, so it must have been a good conference. So we're going to be talking about eHealth, about closing the gap, and so health disparities is one of the main topics. And so I looked up what is the definition of health disparities that's out there. So Medline defines it as health disparities refer to differences between groups of people. These differences can affect how frequently a disease affects a group, how many people get sick, or how often the disease causes death. So based on kind of that starting point of a definition, how do we think about disparities? And so I'm going to give a little bit of how we think about it at HCMC and then a bit of national context for some of the conversations going on, and then we'll open it up and hear some answers to some questions from our panel, and then we'll have time for all of you to have questions as well. So one kind of disparity is a population-based disparity. So at Hennepin County Medical Center, we serve the most vulnerable regardless of their ability to pay. So 84% of our population are at 200% or below of the federal poverty level. And we want our population to receive the same quality of care as every other population. And so there's been increasing attention in recent years to the problem of health disparities in our country and in our state and in our cities. And one of the concerns is that large amounts of money are being moved away from safety net providers who are working to reduce these disparities because of the extra challenges that these providers face. And so I had the opportunity to be the member of an expert panel that was convened last year by the National Quality Forum to make a recommendation on whether nationally endorsed healthcare performance measures should be risk adjusted for social determinants of health. So we've heard a lot today about how important those social determinants are in affecting outcomes. And so the question about how to do performance measurement and how to take those things into account is a really key one, because we want providers that care for vulnerable populations to be able to continue with that important mission. So the panel ended up recommending that for the purposes of identifying health disparities, healthcare measures should be stratified or reported by those categories, because if we don't report by those categories, we won't understand if there are differences between groups. And so that was one of the recommendations. And the panel also recommended that for the purposes of accountability, so public reporting and pay for performance, that some performance measures should be risk adjusted for sociodemographic factors, and there are specific criteria for when you would consider that. And so the National Quality Forum report has lifted the restriction against sociodemographic risk adjustment during a robust trial period that's going on right now to see how this is going to work. And it's consistent with other groups nationally and locally that are recommending similar changes and making progress on methodology and readiness. So how are we going to collect this social determinants information so that we understand it, can have the right interventions, and then the appropriate risk adjustment. And so what Mitch talked about this morning, the IOM report that he was part of on capturing social and behavioral domains in electronic health records is really an important work that we're all paying attention to that's going to help set the future direction for how and hopefully getting some standardized ways of collecting social determinants of health data. There's also some new legislation in Minnesota that's exciting that you may or may not be aware of. There was a new law in Minnesota that requires us to stratify quality measures by race, ethnicity, language, and country of origin. It also requires the quality incentive payment system to adjust for variations in patient populations to reduce incentives for providers to avoid high-risk populations. And then under Linda Berglund's leadership, who I believe Linda is still here, I think I saw her, there she is. We have a new law that clarifies that data may be shared between social services and healthcare organizations for purposes of care coordination for public program clients. And this is really a breakthrough because of some of our laws, we really had questions about what data we could share between social services and healthcare, which made it difficult to take care of a person holistically and really look at how we can have interventions to address the social determinants to have a better health outcome. So that law has just been passed this session as well. And then within Hennepin Health, which both Jennifer and Stella have been part of, we have believed that we need to go out beyond the traditional boundaries of medical care in order to address social factors. So eHealth is helping us to do this. One of the things that we're doing is using the electronic health record as a common place for shared documentation. So between social services and healthcare, so that we have a common way that we can be sharing that information and having interventions that are holistic. And then also, in a more macro sense, bringing social services and healthcare data together in a data warehouse, which we can then use to analyze holistically to make sure if costs are going up in one area that they're not that we're reducing them in another area and looking holistically at that. And so you'll hear more about those interventions from our panelists. So next I want to introduce our panelists. So first we have Stella Whitney-West, who's the CEO for NorthPoint Health and Wellness Center. Jennifer DeCubellis, who's the Assistant Commissioner for Community Supports Administration at the Minnesota Department of Human Services, and really has been a role model for me and a lot of other people in how to see solutions instead of problems and really get things done in this area. And then Abdul, who's the CIO for UCare. So I'm going to start out with our first question for the panel. And the question is, what does health equity mean to you and to your organization? And Dan, we'll start with you.
Absolutely. So similar to Hennepin Health, UCare really focuses on low-income members. For those of you that don't know UCare, we're a health payer. We focus heavily on low-income individuals, folks on disability, and traditionally, folks that have a harder time getting access to the right health care. So for us, when we look at health equity, it's besides the social determinants, I think one of the things we always highlight too is there's also a separation by diagnosis, and a big part where we see that line is if you look at mental health versus other things deemed physical health care issues. So being able to solve for those challenges and provide the same level of care. And then I think one of the big ones that specifically applies to the state of Minnesota is looking at rural communities versus the urban community, because that's another set of challenges where it's not necessarily associated with economic status of the community, but just their geographic location too. So understanding all those different dimensions by which you can affect or drive a standard quality of care is really the way we look at it.
I would just echo that and add to it. Some of the best discussions I've heard have been about equity versus equality and where our starting point is for individuals in healthcare. So a 2-week appointment for me to see a prescriber might be reasonable. A 2-week appointment for somebody whose life is in crisis and has all the social challenges of being in poverty, being in a shelter, being in crisis isn't equity. It really is about looking at where the person is at and how do we ensure that everybody has equal access to the same outcomes, not equal access to appointments and time frames. We often found in Hennepin Health that where the individual was at, we were setting them up for failure to begin with. So it really is important for us to look at those social disparities and talking to somebody about the importance of taking their medications and then documenting why they're non-compliant doesn't go very far if we don't understand that the reason that they can't do that is they don't have transportation to get to the pharmacy. They're trying to figure out where they're sleeping tonight or where they're getting their next meal from. And so for me, it's more about what is the starting place for that individual and how do we give them a step up to ensure they have the same successes as others.
Well, there's always the benefit of being the last person to be asked a question is that you could just say ditto, ditto, ditto. So I will say that, but in addition to that, we also look at the idea of bringing the resources to people based on what their needs are so that they can achieve the same level of equity in terms of the same level of health, overall health. And no matter what that, what those resources are. So some of the ones that have already been mentioned around social determinants of health, but also there are resources that you may not even be aware of, particularly if you're dealing with someone who's of a different culture, someone who speaks a different language, someone whose life experiences is different. Those are not always necessarily identified in a set menu of social determinants. And so part of that, at least for our organization, is that we ensure that the staff that we have reflects the population that we serve. So we use a lot of community health workers, we use a lot of interpreters that we consider them as patient advocates. So they're not only interpreting for the differences in language and helping to bridge that between the patient and the provider, but also for the culture, understanding the different nuances that a provider may not necessarily have that information. And so making sure that that information and those resources are available for that patient.
So we talked generally about the definition for health equity, and the next question is, how does eHealth intersect with that? So what can the role be of eHealth in helping to reduce disparities and bring about health equity? One small example from what we're doing at Hennepin County Medical Center, we are experimenting with developing a homeless indicator that we're calculating from our actual patient demographic data. So we mapped all the homeless shelters in the area and constructed an indicator where if a person reported an address at one of those shelters or a general delivery mail address, we said, well, that's an indicator that they might be in an unstable housing situation. And we're using that as a way to start to target people for interventions and do some predictive risk modeling. So that's just one very small example, but I'd love to hear from, maybe Dan, you could start.
Absolutely. You know, one of the things I always point out is sort of like equality and equity. With eHealth, I think there's several layers to it. You know, there's what we all are more familiar with, you know, if we look specifically around electronic medical records. But as you take a step out, there's tying that into a health information exchange. There's also the connection with other folks in the continuum. And then you talk about capabilities like mobile technology and telemedicine, right? And I think it's really important to look at it holistically because you're able to address a lot more issues. One of the things one example I always give is looking at rural India and how they drove down the infant mortality rate and it wasn't even the use of smartphones, it was the use of regular mobile phones at specific locations where people could go and check in. So fundamentally, when you try and address a lot of problems, communications always comes in. So one of the key roles of eHealth is really creating conduits of communication that didn't necessarily exist before, right? And looking at it broadly. So in some cases, you're using the analytics component of eHealth to drive what you do. We could also use that to influence policies and understand that it's not a one-size-fits-all, meeting the patient or the member where they're at. And then you can also start to incorporate things around culture and things like that. You look at rural Minnesota and, you know, talk about certain specialty cares that it's so difficult to get in certain areas, or you know, at this location now, I mean, I could probably find every type of specialist within 20 miles of me, right?
Guaranteed.
But then you expect someone else in northeastern Minnesota to have to drive, you know, 30 miles or 40 miles for an appointment. Well, that's where things like telemedicine can come in, you know, and other modalities. So I think there are lots of avenues to use eHealth in solving challenges with equity.
Stella, did you want to give a few examples on that one?
Well, one that I was saying from a provider perspective is that we use our electronic health record not only to record all the data and information that a provider might need, but also communication. So in our primary care, we have embedded behavioral health practitioners, and they are on availability on kind of like on call as needed. And so if a primary care provider is in the room with their patient and they're recognizing that this is a patient that I really need to have assessed, that there are some issues going on, well, they quickly can send a message to that behavioral health. We call them behavioral health consultants, but they are PhD level psychologists. They then get that message right away along with the patient information. So they're starting to work on that right away, and then they know that they are then going to be called into the exam room. Well, they're already been prepped. They already have, in real time, got that information. And it's particularly important with vulnerable populations that when you've got them there, you've got to try to get as much done as you can, because once they walk out the door, trying to get them back in for an appointment, you know, not going to happen. And in particularly, if you have a concern that this is a patient that may be in crisis, but you need to have that assessment, you need to have that done right away. So we've been able to use our electronic health record, and we're on Epic to be able to do that. The other is that the data that we collect on the patients, including social determinants, their race, language, we also use that data to educate the provider and the provider panels on how their panels of patients are doing. And they can look at their data based on race, they can look on it based on gender, they can look at it based on country of origin, language, and then can really start making some decisions about what, if there's a particular group of their patients that are not doing as well as to be expected, then they can start doing some problem solving. So it's been a tremendous tool for us, because oftentimes if you don't have that data, you're kind of just thinking, well, I think maybe, but I'm not really sure. But getting that data, and then we found that when the providers are sharing that data, then they're starting to problem solve together, and it's made a big difference.
Jennifer, did you want to give an example on that too?
Absolutely. So I think that when we talk nationally about healthcare in Minnesota, the assumption is you guys know what you're doing in Minnesota. You don't need new funding. You don't need new bells and whistles. And when we start talking about the disparities, I think that's when the conversation changes. And I think one of the aha moments for me was when our public health department actually in Hennepin County, a couple that are here, showed us some graphics that showed us here's our health outcomes across Hennepin County, but now here it is sorted by different economic groups, by different cultural groups, and we saw that there was a huge gap. And just having those graphics allow us to change the line. Awareness is the first thing, and then what are the interventions we can do? And I think as we become as a state more focused on outcome-driven care, there's a huge positive there, but it also, we need to make sure that we don't delve so far down into, or roll it up, I guess would be the opposite, that we roll it up and show the pretty picture, but we also have to call out where those disparities exist so that we are driving different deliverables and different approaches to bring those lines gradually together. I would add to that is kind of the public health data coming together with data from health systems, which I think is critical. And then there's also data that sits outside of our healthcare world. We see that, again, a lot in the public programs of chemical health data. Oftentimes sits in the human services systems and not in the healthcare systems. And similarly with behavioral health. Some interventions are in healthcare, but many are in welfare. And the more opportunities we have to bring that data together, the better opportunity we're going to have to really change that health equity discussion. Individuals with disabilities, again, very different needs, and we need to be able to call out those subpopulations better than we have. And I worry a little bit that the more we become outcome-driven and funds are attached to outcomes, it's a good thing. But unless we call out those subpopulations, do we create perverse incentives for folks to not call out where the data does need to improve?
That's a great point. So as you mentioned, Minnesota is often touted as, having really high quality compared to the rest of the country, et cetera. So why is it that Minnesota has been challenged when it comes to health equity compared to other states? Who would like to start with that one?
Well, I could say that it's about the fact that Minnesota is doing so well for majority population that the bar is really high. And then when you look at populations of color, that creates that huge disparity. So that's number one. But also I think that, and I'm assuming that this audience is certainly aware of Dr. Ellinger's report on advancing health equity, where I think he was very, very specific and called out the fact that when you've had decades of structural racism that has not been addressed, then those disparities just continue to grow. And when you have policies and policymakers who are out of touch and really don't even recognize and really don't even have the discussion around the disparities and how can you make changes, or even looking at the policies that they do make and looking at it through a health equity lens, then again, that disparity continues to grow. So, and I know that that is what has been the issue in Minnesota. And so now we're at a point where, you're looking at that there are disparities across the spectrum. So not just health disparities, but what feeds health disparities are disparities in education, disparities in incarceration. And so until you start addressing all of those, and you have to address them at the same time, you can't just say from a silo, else, oh, well, let's just focus on the education disparities and think that the rest is going to, no, they really have to be addressed simultaneously.
And I would just add to that I think that's a lot of the experience we had through Hennepin Health was leveraging each other, that it's all about taking a person, not a program, and looking at the whole person. What are the needs of that person? How do we bring data together to paint the picture of what those needs are? And then how do we deploy each other? We talked a lot about virtual teams, which was a great way to say, gosh, there might be somebody in the correction system that's working with an individual. There might be somebody in the shelter. There might be somebody in the healthcare system, in social work. There's a lot of players involved in people's lives. And can we use data and eHealth information to start bringing those virtual teams together and have them team differently in order to address the disparities?
No, and I have to agree. But one thing I'll call out is that it's not that the rest of the nation is not facing this challenge, but to Stella's point, when you have set a high bar, from an average standpoint, right? There's a greater disparity when you look at it, if you look at it statistically to your outliers, right? And so when we start looking at Minnesota, you see us doing overall really well. And let's take cultures, for example. I think Minnesota is really great in the fact that 1 minute you can be in a certain neighborhood that is mostly of European origin, and then you travel a few blocks, and then you're in a neighborhood of where it's mostly of African origin. And if you try and apply the same things that have made you successful in one area to another, it doesn't necessarily work. In fact, a lot of times it doesn't. What drives certain behaviors, and how do you, even when we say non-compliant, what are the factors that make someone compliant or non-compliant is drastically different when you move across cultures. So our success is also our challenge. The fact that we continue to grow in terms of diversity creates a challenge, and also the sprawl of the state, right? So you look at smaller states that have 5 metropolitan areas, and then there's Minnesota that is big as far as geographic areas and really one main metropolitan area. That starts to create a challenge. How do you get this specialist to start up a network in some far rural place? Where's the incentive to do that, right? So we have to address all of those issues to actually solve the disparity problem.
Thank you. So would the panel be willing to share what you have learned in your work in addressing health equity that you'd like to share with the participants? If someone's interested, where should they start? What are some good tools and resources? What advice would you give folks?
So I could start. I think, as being the only technologist up here, I think, so I represent the E, and the health is everybody else. But no, on a more serious note, I think there's the challenge to simply look at some of the capabilities of eHealth as new whiz-bang technology tools, right? You can implement a really good electronic health record system, but as long as we don't truly look at it as a tool that can really help solve the medical problem. And one of the things I've learned in my career is, the worst thing you can do is bring new technology and hand it to nurses and say, thou shalt use this, right? You'll quickly find out how limited authority you have in the organization. So, there's that transition that we're going through, so helping people adapt and make that transition in order to be able to leverage it. I think there are a lot of really good resources out there, from CMS has a whole page on, their roadmap on what they're trying to do with eHealth. I think here locally, the Department of Health has done a really good job. And a number of, my colleagues that I hear on the eHealth advisory group, the community itself getting together and having conversations of how do we make this work. But so it's almost a no wrong door approach, right? Whether you want to look nationally, state level, or at the community level, or even within your organizations to talk to folks of, okay, what does this eHealth really mean, and how does it change the way I engage with my patients and our members going forward?
And I would just add to that, I think that what we found is that look nationally at what's happening, but also look at who are the partners you need. I often talk about Heads Up Healthcare. It's not about my program and my world, because we take care of people that are much more complicated than that. So what are the natural partners in your local community that need to come together so that we're all heading in the same direction? And a part of that partnership is, how do we do healthcare together and get better outcomes together? The other part of it is, how do we do the technology? It always worries me when I see lots of little pockets of innovation happening, and I go, gosh, nationally we're all struggling with this. So how do we use each other and what we've learned to get platforms that work for the state or the community that can be refined? I think I worry a lot that we're dumping a bunch of information into data warehouses or information, and if you can't use that information and get it back out in an easy format, we've lost the war before we've begun. And I would credit Nancy's expertise quite a bit with Hennepin Health of creating dashboards. So it was about getting data into a system, but then what is the critical information that I need out of the system? So when our technology gurus get it in our fingertips, but it's so deep because we've made it so complex, nobody's going to use it. So how do we create dashboards that, based on my area of expertise, if I'm a community health worker, what I look at is very different than if I'm a physician, or if I am a corrections staff working on a probation plan to keep somebody in the community. So how do we bubble up the data that is important for people and not overwhelm them with data that becomes very quickly not user-friendly? And if we can do that as a community versus as one-offs, the resources we save by not having everybody try to figure this out in isolation is huge.
And before we hear from Stella, we're going to open it up for questions after this, so start thinking of your questions for the panel. Go ahead, Stella.
Well, one of the tools, and so you talked about it, is that, and one of the challenges that that we have is how do you get just time for staff to even learn how to use different tools, or even to be able to attend seminars and things of that nature. So one of the things that that we use a lot are the webinars, and we see more and more of those becoming available through our national association and even our statewide association. MINAC does a lot of those communications through webinars, and we found that those are very, very effective, and we get more of our provider staff who will listen to those because they can either participate in real time, or they can go back when they have a few moments and listen to the webinar. We've also found that particularly learning about different cultures. So here's a plug for a Stratus Health class, the Culturally Linguistic Appropriate Services tool. And we have been using that tool now about, I'm going to say 4 years, something around there. And we have found, so what it is, it's an online assessment that your providers can take, and it's a way of tracking how they are becoming more and more culturally, linguistically able to be responsive to different cultures and across cultures. And the first year, we got a little bit of participation. Each year it has grown, and what is nice about it is that we can look at the data in an aggregate to see how are we doing as an organization, and we can look at the data based on different departments. We can also then, each individual can look, because now we have the historical data that says that how they have improved over time, or where are the areas that they need to work on. And so that has been one particularly that has helped our providers become more what we call culturally responsive. I also think that my chart, so when you talk about being able to communicate with your customer or your patients, and through my chart, we learned that you actually have to have training in something that is available so that patients understand how to use it, because not everybody is, technically savvy. So we set up community health workers in our lobby that can interact with patients, give them a demonstration. We also have a computer lab that they can go in and they can sit down with someone and very confidentially so that they can go in, do their password, and they can kind of understand how that My Chart works, where they can find information, and how they can send an email to their provider and get feedback. So those are the ways that we've found and the kinds of tools that have been really beneficial to us.
So questions from the audience. Please, if you have a question, you can step up to one of the mics, either here or there.
Everybody wants to go home, right?
What was that about iPads, if you ask a question?
Oh, yeah.
I'll ask one follow-up while other people can think of questions. So Stella, you mentioned My Chart and kind of the patient portal idea. Have any of the panel members had experience with kind of segmentation of their patient panel to understand how different cultural groups, people of different economic levels might interact with technology differently, and how do we start to think about that so that we're really communicating with patients in the way that they want to be communicated with?
So I think UCare as a whole, we've done spent a lot of time meeting with community leaders and different community focus groups to understand different cultures' approach to communications and technology. And we always assess when we're rolling something out, where is it going to be effective and where do we have to give that additional training. But I think sometimes you always have to look at things from the eyes of your member, your patient, right? So if I'm a native, Spanish speaker, and there are other things besides just the translation that go into play from my culture, how does this meet or not meet my needs, right? What things, because when, you start from the folks that are building the technology, we build and envision things based on the way our world has been, and we don't realize it when we're doing it. So I think it brings an interesting dynamic. One of the things we're doing at UCare, even internally when we talk about being able to have the right information to the right person, because the value of information diminishes really, really fast, especially healthcare, right? So we talk about someone living at this address in a homeless shelter. Well, that's still true 2 weeks from today. So we're deploying technology capabilities that allows us to present the right information to the right person at the right time, but allow the technology to take some of the burden of saying, okay, you're a social worker, so you need to see this versus, and it's all the same information at the back end. And then the next step is to look at how we do that with members. So based on all of these assessments that members take in our interactions, to be able to say, all right, we know whether it's a personal or whether it's a cultural preference, to be able to present things based on those, right? Because we focus on cultural and these social things, but also there are things that are just individual to us. Some of us learn better a certain way, right?
Well, one of the things that we found is I call it the younger generation, or particularly teens, because we have a teen clinic, is text message. It took us a while to figure it out, but doggone it, if you send them a text, they're going to respond back, but they're going to respond with a text. They're not going to call you, and they're definitely not going to say, but they will respond to text messages. And so we had to incorporate that. And then you're talking about working with different generations. You've got folks who are like, well, a text message? I don't feel right. Well, if you're trying to connect with someone 16 up to, I'd say, mid-20s, you're going to, parents know that. They send a text message, you get a rapid response. So we've incorporated that for sure.
Did you want to comment? No. Okay, go ahead.
So there are a number of people at the summit who are from the rural parts of Minnesota. And so, Daniel, I want to pick up on the rural mention that you made a little while ago. We know that there is a growing diversity in terms of racial and ethnic and language in our rural communities, but we also know that in rural communities, they tend to be older, with more chronic disease, and poorer. And so we have that complexity layered on poverty and access as well. So I'm wondering, maybe it's particular for Daniel and Jennifer. Stella, you're, I know, very urban focused. But Jennifer, with your DHS statewide hat on, and Dan, that UCare serves across the state. I'm just wondering if you could talk a little bit more specifically about addressing disparities and equity looking through that rural lens, and if there are anything in particular that you're doing or that you have plans for that might be more rural specific.
Absolutely. I think that's a really great question, and it's always important that we always highlight those parts of disparity. But when it comes to the rural, so start first when you think about a plan, right, a health plan, what the general network adequacy guidelines, is not necessarily sufficient for a rural environment. So the first step for us as a health plan is understanding that and saying, yeah, those guidelines is an average and works really great in Hennepin County. Well, you move to outlying counties, doesn't work well. So how do we augment that, and how do we create a greater standard to say we have this number of specialists within a network to say that, yes, that network is actually sound. But then it also goes to things like the point that you mentioned, mostly elderly, and UCare, one of the things we're known for is our elderly population. So we love them and we've come to know them well. But some of the challenges of now we're dealing with this sort of split population of younger people text me if you want to talk, don't call me, don't write me, don't nothing. Well, there's the other side of the coin. Well, don't try and text me because my phone is just for speaking to someone on the phone, right? So, and that's where it's really trying to separate those and not try to treat them all as once, and keeping that personal touch. You can, we IVR, the interactive voice response, is almost like a 4-letter curse word, and why is it so? Because people always say, you're CIO, why you don't do more with that? Well, our elderly population do not like it, right? It's a bad way to interact with them, So we're always trying to strike that middle balance. But the sort of second layer of eHealth that we should not forget is, well, how do you address some of these access issues? And I think that's where things like telemedicine come in. One of the things, I know, so I'm a retired Army, and I always tell people about advanced surgery taking place in battlefields, and the surgeons are nowhere near the battlefield. One of the things is, as a country, we've learned a lot from our military, and I think that's a really good example of, it's a different discussion now when, you're asking someone take, a 4-hour drive down to St. Cloud to get a surgery, versus do we start to focus as community and say, let's create these centers and use them, and your network could be coming in technically from out of state, if needed.
And I would just echo some of that, in that I was in Ely, Minnesota yesterday, and my biggest learning going out there was I scheduled conference calls all the way out. I accomplished 1 of 5. There's no cell service. I was on no service, and extended service at best as I approached some hills, but no service most of the way. So I was doing a health work with that community of how do we bring their human services and healthcare services together, and broadband just doesn't exist. So a lot of individuals that they wanted to use technology to reach out to didn't have that. So it was about creating technology hubs. So where in town can you get a good signal? Where do you have broadband? How do we start creating hubs where people can come in and have free access to check emails, to check notices, to log on to their health records? But even more importantly, the providers out there, they wear many hats. So they can't be just a healthcare provider or just a mental health provider. They really are kind of a community hub. And so it's really starting where the community is for eHealth and for the disparities. As we were talking simply, okay, well, you have Essentia in your town, and they have Epic, and how can we do affiliate agreements to get your behavioral health and your chemical health and some of your other resources, so at least we're all talking to each other in that virtual team concept. So it was an interesting approach. They were very open to telehealth. Even their elderly population said, you know what, we'd rather be able to see somebody on a TV screen, even though it feels funny, than you tell me drive 2 hours to Duluth to get services. So with some coaching and some encouragement and staff with them, they were very comfortable reaching out and doing some different types of technology. But it is looking at the environment.
And one other kind of basic infrastructure element is internet access. And interestingly, the FCC just a few weeks ago has made a proposal. For years, they've been subsidizing telephone service for folks, for low-income folks, and they've made a proposal to now start using those funds to subsidize internet access, broadband access. I don't know exactly what happens next, but that's a really interesting kind of development in eHealth, because that basic, is that a basic need for people in order to kind of survive in our world? And it would be great for eHealth if that became really something that everybody has as a baseline. So,
can I make 2 other points, Nancy? Some other things that I've just been tripping across that kind of fits with this conversation is, one is when we talk eHealth, attorneys can't lead the way. As much as I love attorneys and their protections, I think that was our biggest challenge with Hennepin Health. It's what I talked with the community about yesterday, is they went, but the attorneys keep saying we can't. We need to have attorneys inform us about the risks. But when I talk at the federal level, people go, when you talk about chemical health, nobody's ever been sued for sharing information around chemical health, and the 45 DCR, whatever that acronym is. People aren't getting sued for that, and there aren't findings. So why are we all using that as a way to not connect systems electronically, and to, again, manage our risks, manage our understanding of what those risks are, but not have that drive the way healthcare goes. It's more about talking about how do we get there, not no, you can't. And we heard that a lot in the rural communities. And I also wanted to follow up on a point Stella made about equity in policy. And just to flag that we've had those discussions at DHS in particular as we've gone through this last legislative session, where we've had a lot of policies being drafted around chemical health, mental health, healthcare services. And a part of our process is to look at, we do fiscal noting, we do policy reviews and analysis, and we are looking to put in place an equity review. That happens as legislation comes through, for us to look at that equity lens and flag where are we setting the bar that would disadvantage somebody. To your point, we can't take Hennepin as our gold standard of if it works in Hennepin, it works everywhere else. And to look through that equity lens more consistently to try to address that.
And if I can just add, even though this was for rural, but I think that across the board where particularly telemedicine comes into play is the fact that we have positions where there is just huge shortages. So psychiatry is one that we know, and it's going to take us years to get to a place where we're able to fill that gap. So one of the things that we are piloting in as a part of Hennepin Health is the telepsychiatry, and having a psychiatrist who is available to provide the consultation to the primary care docs, because they are the prescribers, and they are not very comfortable prescribing meds without having that link with a psychiatrist. And so being able to do that allows us then to meet those needs in those areas where there's just a huge shortage, and that goes across rural as well as in urban areas. So certainly that is an example where I think eHealth is huge. One of the things though, so not only can we not let lawyers lead the way, but we also have to get and I'm going to say the health plans, but maybe it's not the health plans, but somehow or another, and we're starting to break ground, the reimbursement. So in my world, with HRSA as an FQHC, there's still, well, if it's not a face-to-face, physical face-to-face, we can't get reimbursed. So whether or not it's, so telemedicine, which is efficient, cost-effective, works, but the reimbursement. So some of those things we definitely have to get them out of the way so that we can make sure that the system works, because eHealth is great and it's out there, but if the reimbursement policies don't follow it, you can't really implement it.
And that brings up a good point. I think our world is changing around us, whether we like it or not, and I think we as members of the healthcare community have to make sure that we're looking forward rather than just solving the problems today. So telemedicine is one that I think we solved the current problem for too long, and now we're at a juncture where the policies and infrastructure, again, do not match up with what makes sense and what people expect. There was a conversation we're having internally around, how do you drive down emergency room utilizations? Wouldn't it be great if people could just, have a conversation with a nurse through an iPad, and I said, the problem is not the cost of the iPad, because if we could come up with a program where people would use it and it would work, I'd fund the iPad for every UCare member out of my budget, because I'll solve a major community problem. The bigger issue is you go to things like the infrastructure. Are they going to have the network, right? Is it going to be reimbursed, right? Or are laws not yet matching, laws and company policies not matching where we need to be? And are people comfortable using it? But I think as our population ages and the folks that are teenagers now become our elderly, if we haven't built that up, our healthcare system will literally fall apart, because it will be the one sector that people can't interface with.
Last call for questions. All right, well, I would like to thank the panel so much for sharing your insights. And Jennifer's going to wrap it up.
Great, thank you. So I had the opportunity to welcome you all this morning for day 2 of our summit. And what did I say about this panel? I said, don't miss it. I hate to be smug, but I was kind of right, wasn't I? Thank you all. It was really terrific. I appreciate how thoughtful and thought-provoking this was, so thank you for that. So just a few comments, and then we'll be wrapped up for the day. If I think about what makes a successful summit or conference from my perspective, there are a couple of things that come to mind. First is, am I going away with new ideas and new knowledge? Secondly, has some of my thinking been challenged? Have I opened myself up in some different ways that maybe I didn't come into that event thinking about? Have I built some relationships? Have I connected with some colleagues and caught up with some colleagues that I haven't before? And have I made some new colleagues? Have I built some new relationships? And then have I renewed my commitment? Do I have the ability to take some action as a result of all of that? If those are kind of the litmus test, at least in my mind, of whether it's been worth my time for, in this case, 2 days spent here dialoguing and working with all of you, for me it's a resounding yes. I think this has been an extraordinary summit, and I so appreciate all of your engagement and participation, and want to thank once again the conference planning committee, the summit planning committee, for their work that really started a year ago. This takes a long time to get us to the point that we are today, bringing you all together. So my thanks again to the summit planning committee. You will all be receiving an evaluation tomorrow by email, and we take those seriously. We really would ask that you take the time to complete that. Let us know what worked well for you, where you learned and gained and networked and had new knowledge, and then also let us know either what we could do better or what ideas you have for next year. Who would you like to hear from? What topics should we be digging in more deeply? We look closely at those evaluations and actively use them as we do our planning each year. So really do take the time to do that. And then lastly, I would just invite you, if you are already involved in the eHealth initiative in Minnesota, stay involved, and I hope you too feel this sense of renewed commitment to the action that we're taking together. And if you're not yet involved, there are many ways you can be. We have lots of work groups. We have lots of actions, activities, and opportunities for you to become more engaged, and I invite you to do that as well. And so I just leave you with this thought that builds on our theme, that together we can continue to make strides to connect communities to advance population health. So I thank you all, safe travels, and we'll see you again next year and hopefully before then.